Welcome everyone. In today's video, we are going to talk about the anterior deltopectoral approach to the shoulder joint. The deltopectoral approach offers a good wide exposure of the shoulder joint. Some of the common procedures performed through this approach are open reduction and internal fixation for proximal humerus fracture, reconstruction for recurrent dislocations of shoulder, drainage of sepsis, biopsy and excision of tumors, repair or stabilization of the tendon of long head of biceps, and shoulder arthroplasty and hemiarthroplasty. The internervous plane in this approach is between the deltoid, which is supplied by the axillary nerve, and the pectoralis major, which is supplied by the medial and lateral pectoral nerves. Coming to the technique, first the position. The position is supine position and the head side of the table is elevated around 30 to 45 degree. There is a sandbag placed under the spine and medial border of scapula to push the affected side forward and allow the arm to fall backwards. And the arm should be free and should be draped free because the arm needs to be moved during the surgery. If image intensifier is required during the surgery, then before starting the surgery, we have to check whether the adequate views are available or not. The incision is a 10 to 15 centimeter incision from the coracoid process following the deltopectoral groove and ending in the insertion of the deltoid. Following this, we have to find the deltopectoral groove with the cephalic vein running. Finding the cephalic vein can be difficult at times, and there is some fatty tissue generally around this cephalic vein which may help us in guiding to the location of the cephalic vein. Once we find the deltopectoral groove, we have to separate these two muscles, and deltoid is retracted laterally and pectoralis major is retracted medially. Vein is taken to the side, medial or lateral depending on where it goes easily. We have to try to preserve the cephalic vein as far as possible because it reduces post-operative upper limb edema when preserved. Now, once we retract the deltoid laterally and the pectoralis major medially, the biceps tendon and the coracobrachialis come into view. Together they are known as the conjoint tendon. These need to be displaced medially. Now we incise the fascia just medial to the short head of biceps and retract it medially. This retraction after incision of the fascia is generally adequate in a large number of procedures like open reduction of proximal humerus, Magnuson stick procedure, or putty plait procedure. Now in case a procedure which requires a wider exposure, or if the coracoid has to be transposed like a Latarjet procedure, then these are retracted after performing a coracoid osteotomy. When performing a coracoid osteotomy, it is better to pre-drill the coracoid before doing the osteotomy, especially if the reattachment is planned with a screw. This is because the small piece of coracoid, if it is drilled later, may be split during the drilling. So we drill it before we do the osteotomy. Now, axillary artery along with the cords of brachial plexus lie behind the pectoralis minor, which also takes attachment in the coracoid process. Now, if the limb is abducted, this will come closer to the coracoid operative site and is at risk of injury. So we have to keep the limb adducted during the coracoid osteotomy to avoid injury to the axillary artery and the cords of brachial plexus. If a coracoid osteotomy is performed, we have to avoid excessive downward retraction on this conjoint tendon along with the coracoid process because the musculocutaneous nerve enters from the medial side of the coracobrachialis, and if there is a excessive downward retraction, this is at risk of neuropraxia. If the coracoid process has been left intact, generally the attached coracoid muscles prevent neuropraxia. However, even in these cases, you should avoid vigorous medial retraction. Once we retract these conjoint tendon medially, either without a coracoid osteotomy or with a coracoid osteotomy, the subscapularis comes into view, and we have to now divide the subscapularis. So what we do is we externally rotate the limb. It offers many advantages. First, it brings the muscle belly into the wound. It also increases the distance between the subscapularis and the axillary nerve. So the axillary nerve runs near the inferior border of the subscapularis. When we externally rotate, the distance increases from the inferior border. So we have to externally rotate it. External rotation also makes it easier to define the superior and inferior border of the subscapularis as the muscle becomes taut. Now we have to know that there is a triad of vessels running on the inferior border of subscapularis, that is one transverse artery along with two vena committantes. This may also help us in defining the inferior border of subscapularis. Following this, a blunt instrument is placed between the subscapularis and the joint capsule, and the subscapularis is tagged medially with sutures so that we can easily reattach it later and the medial part doesn't disappear medially into the tissues. And then divide the subscapularis around 2 to 3 cm from its insertion on the lesser tuberosity. The other way is to remove the subscapularis with a small flake of bone from the lateral insertion after internal rotation. So this allows a more lateral reattachment later and a direct bone-to-bone repair and healing. Once the subscapularis is divided and retracted medially, the joint capsule comes into view, and the capsule is incised longitudinally to enter the joint. Special situation is in the treatment of fractures of proximal humerus. Here the fracture planes are used for deep dissection. The greater and lesser tuberosity usually have their attached musculotendinous insertion intact, and we can take sutures on these tendons which allow manipulation of this fragment and reduction of the fracture. The biceps tendon, which runs between the greater and lesser tuberosity, can act as a key surgical landmark for bony reconstruction in treatment of proximal humerus fractures. Now let us come to the dangers in this approach. The first structure is the musculocutaneous nerves, which enters the coracoid brachialis about 5 to 8 cm distal to the muscle's origin from the coracoid from the medial side. So the dissection must remain on the lateral side of the conjoint tendon. Again, we have to avoid excessive traction on this conjoint tendon inferiorly, especially when we have performed a coracoid osteotomy to prevent neuropraxia to musculocutaneous nerve. The next structure is axillary nerve, which runs on the deep surface of the deltoid from a posterior to anterior direction. It is at risk from instruments placed around the lateral side of the proximal humerus, as they may press directly on the nerve, causing neuropraxia. So we have to avoid placing instruments in this region and vigorously retracting the deltoid. The second place where it is at risk is just inferior to the inferior border of subscapularis. We already saw it was running inferior to the inferior border of subscapularis. So external rotation of the arm takes the nerve away from the operative site and avoiding dissection inferior to the triad of vessels. So we had a triad of vessel at the inferior border of subscapularis. If you don't go distal to it, this generally protects the axillary nerve. The vessel at risk is the cephalic vein, which is found in the deltopectoral groove, and we have to preserve it if it is possible to decrease post-operative edema. However, a traumatized cephalic vein should be ligated because there is a slight danger of thromboembolism in these cases, as there are no valves between the cephalic vein and the superior vena cava. So friends, in this video we discussed the anterior deltopectoral approach to the shoulder joint. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.